Okay, hello, good morning, everybody. Again, my name is Dr. Tay Kai Sian, and I'm the head of the Foot and Ankle Service in Singapore General Hospital. And I'd like to welcome everybody to the latest in our series of public webinars. Today, our public webinar will be on running injuries in the foot and ankle. Now, running is a very common way of exercise for most of us. It's very easily accessible. Almost anybody can do it. And most of us do it either recreationally or competitively or as a form of way to keep fit. Now, but of course, running, with any exercise, can come with injuries, especially if you train wrongly or it's just an accident and things can happen. So today, we've put together a set of panelists from the Foot and Ankle Service to talk about running injuries, some common injuries, how to prevent them, and I hope that this will be educational for everybody. Now, just a bit of introduction for our service. Now, the Foot and Ankle Service in Singapore General Hospital has got 4 surgeons. So there are 4 of us consultants who do surgery, but we are very well supported with a team of physiotherapists, podiatrists, and nursing to give a full suite of capabilities in terms of treating any injuries you might sustain. So from this pool of experienced healthcare professionals, we can then provide adequate care to everybody. Okay, so this is us. That's myself, Tay, there's Dr. Lee, Dr. Kaiser, and Dr. To as well as podiatrists, physiotherapists, and nursing. Now, today on our panel, we have also Dr. Adriel Tay, who is one of our senior residents. He's a former competitive runner and triathlete with special interest in foot and ankle surgery and sports injuries. And his aim is to promote safe running and longevity in the sport. So he will give a talk on a runner's perspective and how he has overcome some of his own injuries. This will be followed by Dr. Kaiser, who will give a talk on heel pain, which is one of the most common injuries that plague runners at all levels. He's a consultant surgeon and a biomedical engineer as well, who specializes in foot and ankle surgery with interest in biomechanics as well as frugal innovations in global health. Dr. Lee will then give a talk. Dr. Lee was a consultant orthopedic surgeon as well, and he's dedicated to foot and ankle surgery. He specializes in managing trauma, sports, forefoot deformities, and arthritis, has completed advanced fellowships in 2 centers and has a lot of experience in dealing with both acute trauma and chronic issues in active individuals. And last but not least, we have Jason, who is our physiotherapist, and he has worked across various physiotherapy services, taking care of sports injuries and post-surgical care. He's also a runner as well himself, training regularly, and runs with a running club focusing on strength and conditioning. So he is very well experienced and knows a lot of the challenges that athletes face. So without further ado, we will now start the webinar. We'll start with Dr. Adriel. So over to you, Adriel.
Okay, let me just bring on my slides. Share. Okay. Hey, good morning, everyone. All right. Okay, so thanks for joining us this morning. My name is Adriel. I'm an orthopedic resident and registrar, as well as also an active runner. I hope that currently my both roles as a doctor and runner, I'll be able to help give you all some useful perspective to our listeners this morning and with my sharing. So in this background, I chose this was actually a nice running track in Hong Kong in their right beside the Victoria Harbour in their business district, and this was just after a painful 1,500-meter race. Okay, so a little bit more about myself. I've been active in sports or running actually since my junior college days, and life as a student athlete at that time was very challenging but also very rewarding. We had both local as well as and actually I even went on to do triathlons just to find another 2 more ways to get injuries. So subsequently, I slowed down a little bit to complete my medical school and start with my orthopedic training, which I still am about to complete it soon. So in Singapore, I think we are fortunate. We have many different races, such as now High Rocks is becoming popular. We have the Stand Chart Marathon. This is the NTUC Eco Run, and even for people who are not competitive runners, there are actually a lot of places, for recreational runs, such as our park connectors around Marina Bay. This is at MacRitchie Reservoir, and my personal favorite, which is the Green Corridor. So what's so unique about the foot and ankle when it comes to running injuries? Okay, so with every step that we take when we run, okay, each foot takes up to 2 to 3 times the body weight. For every kilometer, that is 1,000 steps, and it's over 40,000 steps in a marathon. Up to 40 to 60% of runners get injured annually, and a quarter of them actually come from foot and ankle injuries. And just to make things worse, we are always on our feet and they don't get to rest. We're always out and about walking, so they don't get to rest, compared to, for example, our upper limb. So whenever we run, okay, we get a bit of niggling pain in our ankle or heel. Okay, as we most runners, including myself, the first instinct is to ignore it. Okay, what do we tell ourselves? It's just a bit of tightness, right? Or it'll warm up. Okay, or even worse, we tell ourselves we paid for this race. Okay, I'm just going to do it. Okay, but what I call the runner's illusion. Okay, when we start warming up, we start running. Okay, there's usually increased blood flow when we exercise, or your joints feel more stretched out, and there's less pain. When we run, there's also, of course, endorphins, and which is actually a natural painkiller and actually masks the pain. The brain tells ourselves, hey, you're fine. So as we start to run, the pain goes away, we become encouraged, and then it's very tempting at that point to try to push through the pain. Okay, and sometimes we may actually be at the peak of our season, and we may say we don't want to lose whatever we've done over the past few months. So it's always a lot of factors that make us want to just continue with the training. Okay, but almost certainly the pain always comes back worse. Okay, and in micro tears in our tissues, it grows. Inflammation in the muscle, it builds, and the pain usually comes back stronger. Okay, but with our next run, it gets a bit better again. Then we continue this cycle over and over again, and subsequently, it always catches up with us, right? If you pain, ignore it. It can lead to plantar fasciitis, for example. Some stiffness in the Achilles can lead on to tendon tear. Ankle sprains can result in a chronic instability, or if there's any foot pain that you did not that you just ignore, it can really lead to stress fractures. So in our clinics, when we see, some of the best evidence of this problem is that patients don't come to us when we see them. They don't come to us, 2, 3 weeks after they feel the pain or injury. By the time they come to see us, is about 5 or 6 months later, where they have already tried many rounds of this pain, rest, push through, and they do it over and over again. And we see problems like this, stress fractures. Okay, for example, this in the foot. Okay, at this stage, this is likely that the runner has gone through, has tried to push through his training for many rounds. You get a very swollen and painful Achilles tendon, and this is also showing a very severe case of plantar fasciitis. Okay, there are tears and a very severe swelling. Okay, so why do I say doctors are the worst patients, right? Because this is myself, okay, just after committing the same mistake, in fact, last time, having got after a hip procedure, okay, after a season where I had pain, but I continued training. Around that time, I also had a swollen ankle on my right side, and I had to ice it and tape it. By that time, my whole season of about half a year I had to come to a stop essentially. And everything I built had actually gone to waste. Of course, that was very disappointing period of time. So when we when we feel the pain, of course, when you first start off, I think there are some simple remedies. Okay, of course, realistically, we don't expect everyone to come running to a doctor or the emergency department every time they feel a little bit of aches in their foot or ankle or the knees or anywhere else. Okay, I think some sensible things we can start off with. okay, reduce the mileage, okay, maybe half or whatever is comfortable with you. You can discuss with your own personal trainer or your coach, how to slowly step down the mileage. There are softer surfaces that you can consider. For example, if you usually run on the pavement, in Singapore, we have fairly easy access to the stadium tracks. Okay, so the synthetic tracks are actually quite useful in absorbing some impact as we run, or even grass, running on the grass, if ensuring that it's smooth and no potholes. And I'm sure everyone have heard of the RICE, right? Just simply resting, icing, compression, and some elevation. If you are able to, cross training is also very useful. Swimming, cycling, and also the elliptical trainer. So these are able to actually help you maintain your aerobic fitness and also maintain the strength of those important running muscle groups while your injury recovers. When to seek help? Okay, so pain that doesn't improve, after you've tried all these simple steps above, after a couple of weeks, it's still there. The pain that keeps coming back, especially even when you walk, or even just without running, just walking, the pain is there. Or if it changes how you walk or run, or like most of the time, this will be a friend or colleague saying, "Hey, you seem to be limping a little bit," or when you run, it seems to be a bit different. Okay, or obviously if you see any swelling, bruising, or you can't even weight bear or ambulate. So our role here, I mean, as a foot and ankle team or in our orthopedic department, okay, we feel that, of course, early and accurate diagnosis is important. Okay, the earlier we diagnose it means the earlier we treat it, and the earlier you can get back to running. Because end of the day, all we really want to know as runners is how soon, right, can we get back to training? Because every week we are away, we do lose some of this fitness, so we want to get back as soon as we can. Okay, we need to tailor treatment for both competitive and recreational runners. Okay, obviously the needs of competitive and non-competitive runners are very different. The goals are very different. And finally, the treatment is always it's a team-based approach. Together with the doctors, our allied health, the physiotherapists, podiatrists, and even sometimes our sports medicine colleagues also come in to help. In our team here, we have experienced fellowship trained surgeons. They specialize in foot and ankle. We specialize in foot and ankle care, and we have extensive experience in sports injuries and athlete management. And in SGH, we do have a whole suite of advanced diagnostic imaging, such as MRI, to help confirm the diagnosis. If the pain goes on, and is severe, depending on the diagnosis, it may be amenable to injection therapy. For example, targeted injections like platelet-rich plasma in certain cases can help reduce pain and speed up recovery as part of the rehab. And for more severe or persistent injuries, may even require surgery, and there are minimally invasive options available. Okay, we are grateful to have our allied health with us to complete the holistic care. Okay, so our physiotherapists, they help runners recover by training, rebuilding the strength, conditioning, identifying and correcting any muscle imbalances, and restoring a normal movement. Okay, so their goal is to help guide you through a safe rehab and prevent future injuries as well. We also have our podiatrists with us they specialize in analyzing your foot mechanics and gait. And also by doing this, they help to reduce the injuries and support your long-term performance. So how to access our foot ankle service? Of course, there are a few ways. I think on our primary care setting, the referrals can be made. You can always see our friendly GPs or polyclinic doctors who can make a referral to us. There is our appointment hotline as well that you can easily just pick up the phone and call. And obviously, for more acute or severe injuries, such as very bad sprains, you cannot walk, for example, do consider going down to our accident and emergency, and they will be able to take care of you from there. Okay, so some closing thoughts from me. Okay, so I think as with most things in medicine, prevention is always the best. Prevention is key, right? So ensure you have adequate rest between your training, nutrition. Do train smart. Okay, it's not just about doing more and more mileage. Also, but about the ensuring adequate rest and nutrition and conditioning. Always remember that rest is also training as well. You don't feel that rest means you are taking time away from your training. It is part of the recovery and to bring you to the next level. Okay, respect injuries. Okay, not just foot and ankle, any part, you can be your knee, your hip. Do seek help early and follow through with the treatment. That's very important. And I think most of us here, we enjoy running a lot. Okay, we want to take this sport, and be able to do this, essentially for the rest of our lives as long as we can. So don't let injuries cut short your sport. Okay, so do think of always consider longevity in sports. You can always take a couple of weeks off to recover. It's definitely more worth it than having a severe injury that takes you out for years, for example. Okay, so with that, I hope that everyone enjoys their run and see you at the next finish line. Thank you. Okay. Okay, so I'll pass on now to our next speaker. I will just stop my share here.
Okay, thanks, Adriel. I think that's a very nice perspective on especially your career as a competitive runner and triathlete. And I think it's been very insightful. And I think it covers also many of our audience, I mean, things that they can feel, especially when they train. So having got that kind of perspective, let's move on now to a more detailed talk on evaluation of heel pain and heel injuries, which are very common. And Dr. Kaiser will lead us on that. Kaiser, over to you.
Hello, hi, good morning, everyone. I'm Dr. Buhari. I'm one of the foot and ankle surgeons. Thank you for joining us this morning on a Saturday of all days. And I think we have more than 600 participants here. And we're looking forward to sharing more details with you all as the day progresses. Thank you, Adriel. It was really insightful to really hear a runner's perspective. I'm not a runner. I don't do long distance running, but I do realize that a fair share of our patients are usually patients who are coming in with injuries secondary to certain activities that they've been doing. The topic that I'm going to talk about is heel pain. So this one is a little bit broader because it just not only covers those who are runners. Runners do experience a significant amount of heel pain and they are more prone to injuries around the foot. But this can apply to just about anyone. I've had 17-year-old schoolboy coming in with heel pain. I've had a 20-year-old NS recruit coming in with heel pain. And then I've also had an 80-year-old gentleman who is fairly sedentary, but comes in again with heel pain. So I think this applies across the board. But as Singapore has an aging population, we have seeing more and more elderly. But at the same time, we're also seeing an active aging population. So a lot more of them are being more involved with activities such as running. They want to keep themselves fit. They do line dancing, they do Zumba. So we are seeing more injuries in the elderly as well. So my talk is open for everyone. So this doesn't apply just to the runners. So two of the commonest causes of heel pain are, one is plantar fasciitis, which we all know, which is pain right at the bottom. If I were to point on this diagram, at the heel, usually over the medial side. I'll go into more details later. And then we have the Achilles tendinopathy. So Achilles tendon is right at the back, and then they have pain either at the insertion into the bone, or they could have pain just a bit more proximal, a bit closer up, where they can have pain within the tendon. All right, so we'll go into a little bit more detail as the slides progress. So what is plantar fasciitis? Okay, so if you look at the diagram that I have on the right, you could see an illustration of what the plantar fascia is. It is a thick band of tissue that connects the heel bone, that's the bone at the back, all the way to your toes, and it creates an arch. So this arch is very important for the function of our foot. The strong ligaments, they support your arch and is very important to absorb shock when you walk or when you run. So in plantar fasciitis, what happens is that when the tissue becomes inflamed or it develops small tears from overuse, then it causes a painful condition known as plantar fasciitis, which is basically, in simple words, inflammation or swelling around the insertion of the plantar fascia. And this is why the patients typically come in complaining of pain, which will be long-standing. They'll be complaining that they've been having it for months, some even for years. And, we haven't really addressed what the problem is. A little anecdote, I myself had plantar fasciitis and I had it only on my right side. Why did I have it only on my right and not on my left? I was wearing the same pair of shoes. But why is it? We really don't have an explanation. As human beings, we may have a dominant side and a non-dominant side. But in my case, I realized that the reason why I was having plantar fasciitis was because of my choice of shoes. When I was a junior doctor, we have to walk a lot. We have to see all our patients. And I wasn't wearing the right shoes. I was wearing a very hard, not a sports shoe, but more like a formal shoe. Because I was in formal clothes, and I realized because I was walking so much in these very uncomfortable shoes, I developed plantar fasciitis, which took more than a year to recover. And we'll go through what are the treatment modalities that are there and what steps we can take. So the first things first, let's recognize what the signs are. Okay. And something that's very classic is a very sharp morning pain. It's a stabbing, patients describe this as a stabbing heel pain. And one of the key things they tell us is the first steps out of bed is the most painful. When they're going to the washroom, when they get out of the bed, they put their heel on the ground, they have this terrible pain. And this is one of the hallmark symptoms that affects more than 90% of patients. Another that they tell us is that the pain worsens after long periods of standing, walking, or after exercise. And they may not feel this pain immediate during the activity, but typically after. Another clue to tell us that this is likely to be plantar fasciitis is that the location of where their pain is. The pain is typically concentrated at the bottom of the heel, sometimes extending along the arch towards the toes. So these are some of the signs. And when the patients come to us, this is what they tell us. So we need to understand what are the risk factors, okay? Statistically, when we're looking at data, it is more common in 40 to 60-year-olds, especially in runners and people who spend long hours on their feet. So when in the patient population that we see, I do see a lot of security workers who come to us because they have to patrol, they have to walk long hours, and they're usually in this 40 to 60 age group, and they have to wear certain types of shoes which are not really comfortable. They're not allowed to wear sports shoes. They need to wear formal shoes. And this is a population group that we see often. And studies have also shown that 1 in 10 of us will develop plantar fasciitis during our lifetime. Okay, and that is, so if you have 100 people in a room, 10 of them will likely have plantar fasciitis at some point in their lives. Another factor is weight and impact. So as we all know, if we are overweight, we've got excess weight, there's increased pressure on the plantar fascia, while hard surfaces amplify the impact and the stress. So one thing that I tell all my patients is that, of course, I would advise them to try to reduce their weight. This is one of the advice that we give them. And it is an interesting statistic that 70%, up to 70% of those who are obese can have plantar fasciitis. So that is a significant number. And hard surfaces is very important. Even at home, I advise my patients to wear footwear, wear slippers that are comfortable, that are cushioned, that provide adequate support to your foot, because at home we all live in houses that are now tiled, so the surfaces are really hard, so it's important to protect your feet. Another condition is the foot structure and the footwear. Flat feet, high arches, or abnormal walking patterns can create uneven distribution and stress on the foot, and this can give rise to plantar fasciitis as well. And one of the biggest, and I would think the number one cause of plantar fasciitis would be the tightness of your muscles. So if you have a tight Achilles tendon or calf muscles, this limits your ankle flexibility and increases the plantar fascia tension. So if you have tight calf muscles, and we see this in almost all our patients who come in with plantar fasciitis, that they do have very tight gastrocnemius muscles, or their calf muscles are extremely tight. And one of the first lines of treatment is to get rid of that. So first things first, we need to get a proper diagnosis, and usually it is by physical examination. When you come to our clinic, we will have a thorough examination of your foot. We will feel for the tender points along the heel and the arch. We will check your range of motion of your ankle and also the flexibility testing. So we will check for your calf tightness. Typically, we would do that by keeping your knee straight. We will check how much you can bring your ankle up, and then we will bend your knee and again reassess to see if you can bring your ankle up a bit more. So this gives us a clue with regards to whether or not you've got calf tightness and whether that needs to be addressed. We might get you to walk up and down in the room to look at how your gait cycle is, how your walking pattern is, how much pressure you're putting. We will look at your foot structure, see if you have a flat foot, if you're flat-footed, or if you have a high arch. And also we may assess your footwear to see what are the wear patterns. So when you come to see us, please don't wear the new shoes. Wear the shoes or the slippers that you wear on a day-to-day basis, because that gives us a big clue with regards to what type of wear pattern is there. And we'll be able to diagnose and make a proper diagnosis. We also may do a neurological examination. We might ask you a few questions like, do you have any numbness? Do you have any tingling, like electric current sensation running down your foot? All these are very important questions for you all to answer. So maybe before you all come to see us, you all should write down what are all the problems you all are having with your feet. Do you have any numbness? Do you have any weakness? Do you feel like you don't have the strength? So all these are very relevant for us to know. So then you may ask, so do I need to do an X-ray? If anybody coming in with foot pain, do we need X-rays, or can you just not do an X-ray? So the reason why we do X-rays is multifold. One of which is we'd like to look at the structure of your foot. Okay, so that's one. In plantar fasciitis, you may see a heel spur. So if you look at the X-ray on the top there, at the bottom of the heel, you can look that there is like a small spike over here. So that's the heel spur. So we've looked at literature. Our service has looked at this extensively. Plantar fasciitis is not really, the pain is not because of the heel spur, but we have seen studies which show that you may have inflammation around the heel spur that could cause you to have significant pain. All right. So the jury is still out there whether the spur is the cause of it or not. But then from the literature that we've read, you may have inflammation or edema, we call it, around the heel spur, but the cause of the pain is due to the inflammation of the plantar fascia itself. Another reason why we do X-rays is whenever you come with foot pain, we need to rule out whether you have a fracture. And if you have a fracture and we tell you, no, you're fine, just do your exercises, just to walk, do your running as per normal, do some stretches, then that wouldn't be right, because we're not addressing the problem. The pain is probably because you have a fracture, which we may have not picked up. So that's why when you come to our clinics, one of the first things that we would do is ask for X-rays, and normally we want weight-bearing X-rays. Unfortunately, when you go to polyclinics and when they see you before they refer you to us, they do non-weight-bearing X-rays. They don't do X-rays with you standing up. But as orthopedic surgeons, all of us, especially in the foot and ankle service, very, very important for us to get weight-bearing X-rays, because we would like to see how your foot, the pattern of your foot, does your foot collapse? Does your foot, the shape of your foot when you're standing up? Because that is more relevant to us. And at the same time, we may look out for any patterns of stress fracture. Stress fractures means that these are due to repetitive stress on the bone. And then we may see a sort of like a healing pattern. I think Dr. Adriel had shown one of the X-rays. You can see that there is some new bone forming around. So that gives us a clue that you may have had a stress fracture, and that's why you're having this pain. We may also do ultrasounds or MRIs, and the reason for doing this is it shows the tissue thickness, if there's any tears, any inflammation in complex cases. And at the same time, we want to rule out any stress fracture, because this can be picked up on an MRI, or if there is any neuropathy, that means if there's any nerve that is inflamed, we'll be able to see. And sometimes patient thinks he's got plantar fasciitis, but when we do the scan, we realize it's not plantar fasciitis, but a neuropathy. That means the nerve is being entrapped or inflamed, There's a condition known as Baxter's neuropathy. You guys don't need to know about it, but then that could be the source of your pain. So we don't routinely do MRIs, but if I see you and you're coming back with, I'm still having the pain, doctor, I'm doing the exercise, I've changed my shoes, I've done everything right, and I'm still having pain, we may send you for an MRI so that we can confirm the diagnosis before we do anything more invasive. So this is what we would normally do in our clinic. So what are the management? So the first line of treatment is always conservative. Okay, we don't rush to operate on you all. We don't do surgery on the get-go. We will always treat you first with some conservative measures. Firstly, rest and activity modification. So we would advise you to reduce any high impact activities and avoid walking barefoot on hard surfaces. This is very important. I can't emphasize this enough. As Asians, we like to walk barefooted in our houses because we don't want to bring in the dirt from outside. This is just a cultural thing. But I think we need to change that mindset and probably have a clean pair. I tell my patients, please have a clean pair of slippers or shoes for you to wear inside the house, because you're in your house most of the time, you're standing most of the time, you're walking around your house on a very hard surface, and it's only going to aggravate the pain. When you do have this pain, we would recommend icing it for about 15 to 20 minutes after activity to reduce any inflammation. So one thing so you look at the illustration, it shows a frozen can roll. So what I would tell my patients to take any can of drink, keep it in the freezer overnight, take it out in the morning, and then just roll your foot on it. The first thing you do when you wake up, roll your foot on it for about 10 minutes, 5 to 10 minutes for each foot. And then you'll feel this relief because, you're reducing the inflammation, and then your day progresses. Your pain would be much less as the day progresses. Okay. And when you see us in clinic and when you're in pain, typically that acute type of pain, we may give you a short course of anti-inflammatory drugs to take. So these are medicines just to reduce the inflammation, but I don't recommend you to be on it lifelong or, for a long period of time, because we do know NSAIDs can affect your kidneys, they can affect your heart if you take it for a long course. I normally give acoxia or etoricoxib, about 90 milligrams for my patients, but I give it to them only for about 5 days. And I give them some gastric protective medicine called omeprazole just to help them as well. And then after 5 days, I tell them to stop and concentrate on the exercises, because this 5 days will help them get over that acute pain and they can concentrate on their therapy better. The next line of defense is proper footwear. I can't emphasize this enough. Wear supportive shoes of the correct size. So that's the other problem. We wear shoes and often they are not the correct fit. So we need to wear supportive shoes with very good arch support and cushioned heels. And you need to replace your worn out athletic shoes. Unfortunately, sometimes we may have a favorite shoe and we just continue to batter that shoe day in and day out, and then you see that it is worn out, you don't have a good support, and it isn't giving you it's not doing you any good. So when your shoes are worn out, please replace them. I have just shared a few shoes that are recommended by our podiatry team. So I asked them, and these are the shoes. We don't have any stocks in any of these companies, but these are very good shoes. So if you like to take a screenshot of this particular slide, please do so. And these are the ones that they recommend for support. So normally I may refer you to my podiatrist in order for them to talk to you about your footwear, what you wear, and see how they can provide insoles or how they can recommend certain shoes for you. All right. The other thing is orthotic support. So over-the-counter arch supports are available. You can get this at any of the foot stores, pharmacies. Guardian has them, Watson's has them. Mustafa has a very wide range of orthotics, and they have different sizes, different shapes. You can accommodate each your footwear, so you can go over and check them out. You can buy it over the counter. And what this does is it helps to distribute the pressure and support your proper foot alignment. So the diagram on the right shows a heel cup. So we recommend this for our patients with plantar fasciitis. It's sort of like a silicone gel. You put it at the back of any shoe that you have and just walk with it. So This is something that you all can buy over the counter, and it's one of the initial measures that we would take for patients coming with plantar fasciitis. Often we refer you all to our podiatrist, and another point I'd like to make is when you go to see a podiatrist, it's very important that you all take your shoes that you wear, your shoes and your slippers, even if it's 2 or 3 pairs, take it along with you when you see the podiatrist, because the podiatrist is going to assess your shoe. They don't need to see your new shoes. They need to see your old shoes, because then they'll be able to see the fit, the size, the shape, and they'll be able to recommend, or they can adjust, they can modify your shoes. Let's say there are certain shoes that you can wear to work and you can't wear other shoes. They may be able to add in some insoles, some arch support in order to help you. So it's very important to take your old shoes with you to see our podiatrists, right? Okay, so the next would be gentle stretching. So daily calf and plantar fascia stretches, they improve flexibility and reduce your morning stiffness. So this is something that I strongly recommend. And every patient who comes to me with plantar fasciitis will get this piece of paper with these few exercises that I normally circle for them, okay? First one would be towel stretch. So you put a towel or elastic band around your foot and then gently pull on it and hold it for about 20 seconds, and then you repeat it for the other leg. Another would be for you to do a standing calf stretch. I'll go into details of how you do that next. And then there's another exercise known as a plantar fascia stretch. You stand up at the edge of a stair and then lower your body and then raise your body up. Lower your body and raise your body up. All these, you need to hold that position for a few seconds. If you just do it for 1 or 2 seconds, it's not going to be enough. Hold it down for about 20 seconds. You may not be able to get 20 seconds the first time you do it. Build it up. Do 5 seconds, and then do 10 seconds, and then do 20 seconds. And you have to be consistent in order for you to be able to see any difference. All right. In fact, I had one of my mom's friends, I think she's joined us here in the forum today. She complained of plantar fasciitis. I sent her these exercises, and then 2 days later, she dropped me a message saying that just doing the calf stretches alone gave her significant relief. And I can't emphasize this enough, right? So I'm going to show you how exactly to do it. Unfortunately, I don't have a video, but I'm going to illustrate on this photograph. Okay, so we have a gentleman. He's pushing against a wall. So it can be a bed or a wall. And this is the stance that you need to take. All right. A few factors: make sure both your feet are on the ground and you're not lifting off the ground. So it has to be flat on the ground. Okay. The knee at the back has to be straight. It shouldn't be bent. So you don't bend the knee at the back. And the knee in the front is the one that is being bent. So the knee at the back is straight, the knee at the front is bent, and you're pushing against the wall. So what you're doing is you're creating a stress at the back of your calf and stretching out your Achilles tendon as well as your plantar fascia. So this is very, very important on how you would do it. Okay. And I have a 20-20 rule. It's easy to remember, 20-20. 20 seconds, you hold the position and you do it 20 times. So you do each leg 20 times. And I recommend you to do it in the mornings and in the evenings after you're done with work. All right. So I'll leave this slide here for 2 seconds. If you want to take a photograph, by all means. If you can take home one thing from my entire talk, this exercise is what I'd like you all to do. And if you all can do this, and if you all are consistent, you can get rid of your heel pain, whether it is plantar fasciitis, Achilles tendinitis, or any pain revolving around tightness and stiffness. By all means, this is the one slide that I would like you all to take note of. Okay, moving on. There are other conservative options. Some are night splints. I'm not a big fan, but these are options that have been provided. So these are devices that you wear before you go to bed. It can be a bit cumbersome, and getting used to it can be a bit irritating, but it is particularly helpful for those who have severe morning pain, right? Another measure that we do is we work very closely with our podiatrists and our physiotherapists, and sometimes the doctors ourselves. We do what we call ESWT. So this is extracorporeal shock wave therapy. So you may have all heard about this shock wave therapy, where we give high energy sounds to stimulate the healing in chronic cases. So we may not offer this to you the first time we see you with plantar fasciitis or pain over your heel, but we may offer it to you if we see that it is recalcitrant. That means you keep coming with the similar symptoms despite you doing your physiotherapy and etc. So this is a very non-invasive treatment which we can do in the clinic setting, but we have to get an appointment for you to do this because we need to have access to the machine, to do that. And it can be effective in 60 to 70% success rates for persistent symptoms. Important point for you all to note is that this needs to be done weekly. So you need to have at least 3 to 5 weekly sessions. So every week you need to come for 3 weeks, one after the other, for us to really see an effect or any benefit from you doing this. If you do one session today and you come back a month later to do another, it's not really going to benefit you because the healing process is abandoned halfway. All right. So we would recommend you to make sure that you're available for 3 weeks in continuity so that you can have these sessions one after the other. All right. We may refer you to our podiatrists. They have a shockwave clinic where they do this for you, or to our physiotherapists who are also very well equipped in using this device. Another option is injections. Okay, this is a little bit more invasive. So we give injections. The first one, which I'm sure all of you have heard of, is steroid injections. So corticosteroids with some local anesthesia. We inject this into where you have the most amount of pain. It has an anti-inflammatory effect, and it's usually can provide up to 3 to 6 months of relief. And it's usually limited to about 2 to 3 injections. We don't want to keep injecting into that area with steroid because of the potential tissue weakening and also a risk of plantar fascia rupture. I myself am not a big fan of the steroid injection. I have stopped giving steroid injections for Achilles, for plantar fasciitis or for Achilles tendinitis. I don't give steroids anymore. But one thing that me and my service, we are doing more often now is doing platelet-rich plasma injections. This one is a very hot topic. It has been extensively used for tendon and ligament injuries in sports surgery. And this is where we use platelets from your own blood. So we would draw about 10 mils of your blood. We would run it, we'll spin it on a machine, and we will extract the platelet-rich plasma, which is the top part of that, which contains a lot of growth factors and stimulants, which can really help the tissue healing. Okay, and this is something that we are doing more and more often, for a various number of foot and ankle conditions. And for plantar fasciitis, my patients find this to be very effective. This can be done in the clinic, but usually we do it in the theater because we want a cleaner setting. We would give local anesthesia to numb the area around your foot before we give the injection. We may do it with an ultrasound to guide us. So this is a photograph of my colleague, Dr. Lee. He's doing an ultrasound guided injection of PRP into the heel. Or we may do it by identifying where is your most site of pain and then injecting the PRP into this region. Not only is it giving growth factors into the plantar fascia, but at the same time, we do what we call micro needling, which helps to release some of the plantar fascia and then gives you the relief as well. When is surgery necessary? Okay, so usually these are the characteristics of our surgical candidates. When their symptoms persist after 6 to 12 months of conservative management. So if you keep coming back complaining of plantar fascia type of pain, then we may consider looking at surgical options. If there are severe functional limitations affecting your daily activities, you tell me that you just stop going out because you're having so much pain and your quality of life is affected. And if you have failed response to multiple non-surgical approaches, which means you've done your calf stretches, you have taken your anti-inflammatories, you are very compliant to your exercises and whatever brace that we have given you. You're wearing good footwear. We've tried shockwave therapy, and we've also given you the PRP or steroid injection, and you've still not had any improvement, then we are exploring surgery. What are the surgical options? Firstly, there's something called a gastrocnemius recession. This is to lengthen the calf muscle to decrease the tension on your plantar fascia. So this is because your calf at the back of your leg is too tight. We release part of the fascia around it in order to loosen it up. Okay, and this is typically reserved for cases with tight calf muscles. It can be done endoscopically, which means via keyhole, or we can do an open procedure. So the diagram on the right shows a proximal medial gastroc release, which we release part of the fascia, but this is an open surgery, and the diagram on the top shows how we do it via 2 keyholes. Another is endoscopic plantar fasciotomy. So this is also a keyhole surgery. A small hole is made over the medial and lateral side of your foot. We put in a camera, we identify where the plantar fascia is, and then we use certain hook-like instruments in order to cut part of the tissue. And at the same time, we may augment this by giving you an injection like PRP in order to stimulate healing. Other options are open plantar fascia release. We may make an open incision over the sole of your foot to release the fascia, and also we may remove the heel spur during the sitting. There are some other minimally invasive procedures such as Tenex and Topaz, which uses radio frequency, and these can be done normally in the day surgery, where we are using this device to break down the scar tissue. All right. Let me quickly go on to the next topic as well. Achilles tendinopathy. This is Achilles tendon, as we all know, is the largest and strongest tendon in your body, and it's connecting your calf muscle to your heel bone. And tendinopathy encompasses both inflammation and degeneration, resulting from overuse or sudden increase in physical activities. The condition is particularly common among athletes and active individuals who place repetitive stress on their tendons. Okay, what are the risk factors here? Runners. The lifetime prevalence among long distance runners can be as high as 52%. So 1 in 2 runners can have Achilles tendinopathy. And with age, chronic tendinopathy is more common in the elderly. They may complain of pain and swelling at the back of their heel. This can be insertional tendinopathy, which is more common in active persons, or non-insertional, which is in the older population, less active individuals. So this diagram illustrates what I mean by insertional, which is right at the bottom here where the tendon goes into the bone. And then the other diagram shows the mid portion where the patients may have pain. And commonly the elderly folk do tend to focus on pain over there. Another is obesity. We can't emphasize this enough. Having a good body mass index, a good BMI is absolutely important in order to reduce all forms of injury to your lower limbs. Diabetes can also affect Achilles tendinopathy. It impairs the tendon structure, function, and healing capacity. This is because it leads to very stiff tendons and increases the risk of injuries. So very important when I see my patients in clinic, and if they have a history of diabetes, I do check their HbA1c levels. Okay, I might ask you for it. What was your last HbA1c? Or I might even do it in my clinic, because it's very important for me that I not only address your foot and ankle issue, but at the same time address the problems that can lead to you having more foot and ankle problems. You may have ulcers, you may have wounds, and I want to correct that too. Certain medications, such as statins, a lot of our elderly population are on statins because of high cholesterol and to protect their heart. They may also be at risk of developing Achilles tendinopathy. So it's important for you to tell me, I am taking atorvastatin, how much are you taking? And because this can increase your risk of tendinopathy, and also certain antibiotics can also cause this. So these are the signs. I'm going to speed up a little bit because I think I took a lot of time with the plantar fascia explanation. So some of the signs are recognizing your morning stiffness. You tend to have pain and stiffness along the tendon, especially after periods of rest. So the diagram on the top shows that there's a bit of swelling over there. You can have discomfort with worsens with physical activity, especially like after you have a long run. You have tenderness and swelling. And an emergency warning is if you hear a sudden pop sound and you're followed by inability to rise onto your toes, this may indicate a tendon rupture, which is an emergency, and which means we need to see you early in order to address it. Again, getting a proper diagnosis, very important for us to do a physical examination in order to assess the tendon, the insertion into the bone, where exactly is your pain, where is the swelling, is there any thickening? We may look at you walking, look at your footwear, and at the same time assess how tight your calf muscles are. And we may do X-rays and MRIs or ultrasounds in order to look at the severity of the tendon injury. Okay, so non-surgical management, this is the foundation of recovery, activity modification, temporarily avoid any high-impact activities like running, jumping until the pain subsides. And this gives enough time for the tendon to begin healing. Good footwear, good footwear, good footwear. 100% important over here. And it's very important that you wear the right shoes, which is has a good heel lift, a well-cushioned footwear, and of the correct size. And gradual return, this is very important. You implement a very structured, progressive approach. So work closely with the physiotherapist to get back into your normal activities. So this is one of the exercises which is known as a gold standard for Achilles tendinopathy, which is eccentric exercises where you raise at the edge of the stair and then you drop your heel below it, okay? The physios can talk to you more about that later. Some advanced conservative options, we have platelet-rich plasma. Again, we take your patient's blood, we spin it, and then we take the growth factors and inject it into the tendon or into the insertion. And the benefits include pain relief, improved function, and tissue healing. This is one of my colleagues doing an ultrasound-guided injection of PRP into the Achilles tendon. Surgical options, we have the same thing as we did for plantar fasciitis, gastrocnemius recession because of the tight calf muscles. And then we also have the options of doing an open debridement and the repair of the tendon. So sometimes the tendons are very thick or whether very, very calcified. So what we would do is go in, open up, make an incision at the back, identify the unhealthy tendons, cut off the unhealthy tendon parts, put in some suture anchors, and then we would stitch it down. At the same time, patients, if you look at the top X-ray, there's a bump at the back of the heel. So this can also, it's called a Haglund's deformity. This can irritate the tendon and give rise to repetitive micro tears in the tendon, resulting in the tendon not being as strong as it should. So if you look at the diagram on the bottom right, the X-ray, you can see that the bump is no longer there. We have shaved off the bump. It's the same patient. We've shaved off the bump and we've fixed it down using this surgical technique. After we do this surgery, we may protect you in a cast or a boot, protective weight bearing for a period of time. And at the same time, doing an open approach, we may get rid of other sources of pain from the back of your heel, such as if you're having any fasciitis, which is an inflammation of the soft tissue. Very important for me, a point I'd like to make is diabetic patients, I'm very, very worried about wound healing. And this is a very notorious location for poor wound healing and wound breakdown, because you can imagine when you lie down on your bed, you're putting your weight at the back of your heel, and if you have a wound there, it may break down. So whenever I see a patient with diabetes, I make sure that they have the HbA1c at least under 7.5 before I proceed with this surgery. If not, I would try to get them to, correct their sugars before we proceed. We also do another procedure known as a minimally invasive ZX osteotomy. This is a procedure where we would cut off a wedge of the bone and then reorientate the shape of your heel bone. And what this does is that it reduces the impingement of the tendon and bone. It's a much smaller incision, fewer wound complications, and the wedge of bone which is removed, and we use screws in order to make it stable. So your path to recovery, in summary, early recognition, very important. Come and see us so that we can diagnose and give you the appropriate treatment. I would like you all to be very committed to your therapy, be diligent and do your exercises morning and evening, and keep a note of what you're doing and for how long. And also professional guidance. You can see us, discuss with us, see our physiotherapist, talk to our podiatrist. We're all here to help you. And with proper care and dedication and treatment, a lot of y'all can go back into running and be active and continue to be active. And that's what we want all of y'all to achieve. All right. Thank you so much. And sorry for taking up a lot of your time.
Thanks, Kaiser. That was a very detailed talk on heel pain, and I think has showed us a lot of insights and different methods of treatment as well. So thank you for that. We will now move on to Dr. Lee's talk on ankle injuries, which are also very common, one of the most common injuries we see as well. So, Zhong Xian.
Hi, yeah, good morning. So just giving a short presentation, mainly focusing on ankle injuries. I think Dr. Kaiser spent quite a bit of time and gave us quite a bit of clarity regarding Achilles tendon and plantar fascia conditions. But for today's talk on my part, is mainly focused on the ankle. Right. So main thing today we're talking about common ankle conditions that can occur in frequent runners. What kind of injuries can happen? How do we know the extent of the injury and what we can do to prevent it and to treat it and to alleviate your symptoms? So it's very common for you to get an ankle injury in runners. Up to 25% of running injuries actually include the foot and ankle. And unsurprisingly, the number one major condition that you can injure and sprain will be your ankle sprain. So with every strike, like what Adrian mentioned, your ankle actually absorbs a lot of force, and when you push off, the same amount of force goes through that small ankle joint of yours. So it is without doubt that a lot of load goes through it, and a lot of strain and instability can occur if you do not condition the ankle adequately. So a little bit of basics. I think Kaiser and Adrian did mention a little bit on anatomy, but there are a few things that can potentially get injured in the foot and ankle. So the bones form the major scaffold in the ankle, with the tibia, fibula, the big and small bones in your shin, the talus being the bone at the bottom of the ankle, and the foot bones. Various ligaments, these are the ones that you can potentially sprain when you have inversion injury or rolling injury of the ankle, and the tendons. So the tendons are the rope-like structures that connect to the muscle, and these are the ones that allow you active strength and motion. So common culprits on foot ankle injury. For purpose of today's talk, we'll be focusing on the lateral ankle sprain. So this is the classic rolling injury that many of you may experience when you step on irregular ground, you have a misstep, you're not paying attention, you end up tripping and hobbling, and this may actually cause a lot of problems, ranging from fractures, ligament sprains, mouse sprains, or even cartilage injuries. So Kaiser mentioned quite a bit about Achilles tendinopathy. The other one that can bug patients will be peroneal tendinopathy. So this will be a tendon that runs on the outside of the foot and ankle, and often with excessive running, insufficient rest, you can cause inflammation in tendon and persistent pain. The last one that I'll touch a little bit on today will be on stress fractures. So these fractures, unlike normal fractures they experience following trauma, following accident, they may not come as evidently to you. So they may present as mild, dull, aching pain that persists, usually triggered by onset of long distance running. And these pains do not go away easily, maybe probably lasting weeks to months. And usually this is the cause of, this can result in stress fractures that need a little bit of attention. For stress fractures, you do not actually require to be on a cast or boot, but a lot of times all you require is to cut down the level of loading activities or high impact activities, and they can heal naturally. So how do you know if I sprained my ankle versus I broke it versus worst case scenario dislocating it? So very often you have this rolling injury where your foot rolls inwards and your ankle rolls outwards. You'll feel a sharp immediate pain. Very often it can be associated with swelling and bruising. Some patients do mention about hearing a pop sound. In the more severe cases, you may experience difficulty walking for the next few days as well. So a long-term problem of this with the ligament being incompetent or ruptured, that you can feel unstable in the ankle, that you just don't feel as strong exercising or running or playing sports. All with normal scenarios like walking to work and stuff, you may occasionally roll very often as well. So when this happens, the problem with rolling is that it can cause quite a bit of inconvenience to yourself. But underneath it all, you can cause repetitive cartilage injury within your ankle. And you can imagine if your ankle goes through unaccustomed pounding and rolling accidents all the time, you can very easily result in cartilage wear and early arthritis and chronic pain in the ankle. So Adriel did mention about RICE therapy. So that's a this acronym that we use for RICE. But a little bit of a modification to RICE would be the police therapy. So similarly with the ICE, the ice compression elevation that was mentioned, a slight change in this thinking would be that we do encourage a little bit more of loading and ranging. Reason being, this encourages movement and prevents stiffness and atrophy of your muscle. So if you do have pain, of course, you can use crutches or you can decrease the weight bearing immediately following the injury. But when the pain gets better, the swelling gets better, we do encourage some pain-free range of motion. I believe Jason will be speaking a little bit more about this. So in the benign ankle sprains, more often than not, all you require is a good course of therapy, early physiotherapy, mobilization to help in your recovery and return to sports. So when should we escalate then? I think Kaiser and Adriel did mention multiple times as well. So not all sprains, not all pains in the foot and ankle require professional treatment, right? So majority of them can be treated by yourself, monitored by yourself, moderate your activity, decrease your loading. But a few things we mentioned here that you should seek earlier medical attention, be it with your GP or polyclinic. So if you do have problems weight bearing, a couple of steps, then that would be highly suggestive of a fracture. If you do hear a crack or a very obvious deformity of the foot and ankle, then yes, please seek immediate medical attention. Numbness and tingling can be suggestive of red flags as well. Or if the pain and swelling doesn't subside over the next couple of days, even with resting, elevation, painkillers, and icing, then yes, please do seek medical attention. So what can you do in a benign ankle sprain? So we mentioned about police therapy where the main difference is in regaining mobility and range of motion and to prevent stiffness. This very easy exercise that I always tell my patients that a lot of surgeons will tell patients we do this ankle alphabet. They use your toes to spell the A to Z or Z to A, whichever way you want it. Basically just to allow it to move it through the ranges of up and down, left and right, and going rounds. And it is definitely a lot less boring than asking you to make rotations 400 times every day. Right, so Jason will speak a little bit more, but the physiotherapist is actually your best friend in such a scenario, right? So you need to understand that a healing ankle or ankle that's pain-free or less swollen doesn't represent an ankle that's ready to run. Right, so a lot of time and effort needs to be spent on restoring your previous motion, avoiding stiffness, strengthening your muscles, not just your big muscles, thigh and calf muscles for running, but the small muscles involved in supporting the stability as well. Proprioception is just a big term for referring to the sensation and awareness of the foot position. And this can be trained as well to avoid putting your foot into compromising angles that may lead to instability and rolling injuries. And lastly, the therapist will assist in guiding you in escalating the weight bearing and loading to start gradually returning to your sports and exercises. So speaking to a specialist usually comes in when you've tried the course of conservative therapy with the police, with the physiotherapy, exercises, and you still feel that your ankle is not at its best, be it that there's chronic pain or that you feel that's unstable when you run on uneven grounds or if you experience frequent rolling injuries. So like we mentioned earlier on, the main problem, the long-term problem of chronic instability, which unfortunately we often see in professional sports players, is that as stoic and as disciplined as they are, they tend to push through their instability, that they'll sprain, they'll get up walking, and they'll try and go back to exercise and training. But the long-term problem of that is that when you're in the 30s or 40s, you start having excessive amounts of cartilage wear and degeneration. And a lot of times, such injuries are not reversible. And you may end up having to go through a lot of other unnecessary procedures like injections or surgeries just to control your pain, even for day-to-day activities. Or if you manage to do an X-ray or MRI with your primary care physician and they do find complex issues or injuries, then of course a specialist opinion would be warranted. So, in regard to the ankle, what kind of surgeries are we looking at? With regard to chronic instability issues that we mentioned earlier on, the purpose of the surgery is to create a stable physiological anatomically oriented ankle that allows you good range, stable running without the bugbear of chronic pain with weight bearing and loading. So how do we do it? Generally, this can be done either open or minimally invasively, but majority of patients will be suitable and will benefit from minimally invasive procedure with two small sub-centimeter incisions at the front of the ankle and everything done internally without major incisions and wounds to have to worry about after the surgery. So what do you expect after such an injury or such a surgery? Generally, following most the ankle ligament reconstruction surgeries, we will advise and encourage immediate weight bearing. So there's really no need to be on a cast for extended periods of times. So in terms of disruption to your daily activities to work, that will be at a minimal. We will still require some form of dressing on the wounds for the first 2 weeks for it to heal up. And most often than not, we'll advise for some form of ankle brace or guard for the first couple of weeks to allow swelling to come down for the repair to mature. But like we mentioned, the big thing that we require would be early physiotherapy rehabilitation to condition the ankle, prevent stiffness, and gradually escalate you and graduate you to return back to your running. So how do we build an injury-proof ankle? I'm sure this is what most of you would be interested to know, right? Because prevention is always better than cure, right? So strength and balance, so single leg heel raises, exercises, proprioception training, proper footwear as well. So I think there are quite a couple of questions in the Q&A about how often should we change our footwear. So it really depends on how often, how far you're running, but a good ballpark figure would be about every 500 kilometers or so. Smart training, right? So moderate activity, listen to yourself, right? As much as you feel that you're strong and fit and you want to soldier on, it's very important to listen to your body, listen to the pains, swelling that they're telling you. And interestingly, varying the type of surfaces you run on, mentioned by Adriel just now, whether it's the track, the grass, pavement, or treadmill, these can also help rest different groups of muscles or train different groups of muscles along the way. So, Jerry, what do I want you to remember after this whole session? So importantly, if you can't remember police, RISE is sufficient, but police is always better, right? Know the red flags, when to seek medical attention, and please be cooperative with physiotherapy. Very often, I have patients when we suggest to get physiotherapy assessment and rehab. The first question they ask us is, what would they do for me? Can't I just do it myself at home? So the answer, unfortunately, is no. Physiotherapy does provide a lot of benefits, not just in terms of monitoring exercise, but they do provide a lot of education in terms of what you can do yourself at home, right? Going to the gym, going to exercise, it's not about seeing your trainer, your fitness trainer once a week, twice a week. It's about what you can do for yourself on a daily basis to aid your recovery. And importantly, like we mentioned earlier on, prevention is key, treatment is secondary, right? Thank you very much for your time.
Thanks, Dr. Thanks, Dr. Lee, for your very good talk on ankle injuries and prevention and so on. So we'll now go to our last but not least, Jason, our physiotherapist, will give us a talk on physiotherapy, prevention of running injuries in detail, and some of the exercises that we can do regularly to stay fit and prevent injuries in the first place, which will be more important. So, Jason.
Okay, hello everyone. My name is Jason. I'm a physiotherapist at Singapore General Hospital. So it's very great to see many of you here because it also shows that you're not just interested in running, but also in running safely. So the current consensus is that running is safe and it actually brings tremendous health benefits. In fact, it's one of the most accessible and rewarding form of exercise, like what Kishan has mentioned earlier on. But like any other activities, it does carry some risk. And in running, about a quarter of all foot and ankle injuries are related to it. And that doesn't mean that we should avoid running. It basically just means that we need to be very smart about how we actually manage the setback when they actually occur. So I have some good news to share with you today that most running injuries can actually be prevented. So in this session, I will walk you through why some runners have injuries, and most importantly, give you practical tips on lowering your injury risk and help you to return to your running safely if you've ever been sidelined by an injury. So why do runners actually get injured? So most injuries don't actually happens because of one bad step. They literally build up over time. And there are three big reasons why runners have injuries. The first one is the very classic training load errors where people train too hard and too much and too soon. So you need to understand that your body needs time to adapt to the stress of running. And if you ramp up too quickly without giving your muscles to rest, it will basically break. Your leg muscles also need to actually build up capacity in order to be able to cope with the impact of each run. So strength and conditioning is a gap that many of us lack, especially with runners. And also we will be talking about like how the ankle actually move under load, and how we can actually take note and change them when we have pain. So let's talk about training load errors. So one of the biggest mistake is ramping up distance or speeding too quickly. Think of your body like a bank account. If you keep withdrawing without depositing money, eventually you will go into a debt. So training is like making deposit in your account. Things like rest, running, strength work, they all build up. And every run itself is like a withdrawal. So if the withdrawals are bigger than the deposits, then your body will actually goes into an injury debt. So the key over here is that you want to gradually increase your mileage. You want to give your body some time to actually recover. And you actually want to top up with strength training so that your account can actually stay healthy. So it is important to monitor both external load, and the external load that we're actually talking about is distance, intensity, and also volume, as well as internal load about how tired you actually feel after the run. So a good rule of thumb is you want to progress gradually. You want to actually avoid very big jumps in distance and speed. And you might want to actually make sure, or rather ensure, that you don't have a sudden increase of 10% in terms of your mileage, distance, or even your speed per week. And if you are feeling very sore and fatigued, you might want to listen to your body, because like what the doctors has earlier shared on, rest is part of training. And you want to make sure that if any pain that lingers more than 48 hours, you want to actually just unload yourself and seek medical treatments. So strength and conditioning. So did you know that running almost doubled the demands on your leg muscle compared to walking? If you are looking at the statistic right now, the calf and also the shin increases at least around 50 to 90% during a run. And this is why strength training is one of the best way to protect yourself from injury. And in the next few slides, what I'm going to show you is some exercises that you can actually do to keep your ankle strong and to prepare for running. You don't really need a lot of fancy equipments, and exercises can actually be be modified according to how well you actually do it. So for lower limb muscle strengthening, we are actually looking at a few of them. Heel raises especially are one of the key exercises for building very strong calf and very resilient Achilles. So they are not just important in recovery after injury, but they are also excellent as a preventive or even like a prehab exercise. So you want to actually start with double and then move on to a single leg for actually more challenge to basically strengthen your knee and also your hip to actually keep them strong and stable. You want to actually do knee extension exercises. You can do them with or without band, depending on how you actually feel the exercises. And then you want to progress them gradually from about 2 to 3 sets, 8 to 12 reps for a frequency of at least about 2 to 3 times per day. So this is a few exercises that works on the intrinsic muscle. So I think a lot of people actually ask, like, how can I actually train my foot? So short foot exercises, toe curl, or even like toe spreader can actually help to train the very small muscles in your feet. So you can think of them like a core workout, but for your foot. So these exercises can actually help to support the foot better, especially during push-off when you actually run. And strong running also start with flexible ankle. Dr. Kaiser has put a lot of emphasis on trying to improve the range of your ankle. And it is true. A tight calf or even like a stiff shin can actually makes you more likely to roll your ankle or get sore after run. So these are two quick prehab moves that you can actually do to actually help you to run better. Proprioceptive training, like what Zhongxing has mentioned, like standing on one leg or onto a very slightly wobbly surface can help your ankle to stay steady and also react better. So this will make you less likely to twist or even to sprain your ankle when running. Last but not least, controlled and gentle hop. These are exercises where we can actually help you to react better with landing, and also help you to prepare when you actually run. So most importantly, when you are doing these exercises, you don't want to ignore any swelling, limping, or pain that lingers beyond 24 to 48 hours because that's how your body tells you that you need to slow down. So it could mean that you are progressing the exercises too quickly, you are doing too much repetition, or training too often in a week. So in that case, you want to scale back. Maybe switch from doing a single leg to a double leg. You want to reduce the volume, or you want to limit the sessions to maybe 1 to 2 times per week. And then after that, you want to gradually build up your capacity from there to actually help you with running. So now we are going to talk about how your ankle actually moves under load, and going to introduce you to the different running variations. So we all know that we are built a little bit differently, and it's actually normal for people to have variations in how we run. There isn't a single right way to move. What works for one person might not work for another. So since this talk focuses more on ankle injury, we'll look at how the foot and ankle moves during running. So overstriding. So many runners who just started running, and they want to actually go very, very fast, they tend to take very, very longer strides. The problem about this is that when you actually take longer strides, it puts extra stress onto your leg because each long stride actually acts like a mini brake, increasing the impact onto your joint. And by doing that, not only does it impact onto your joint, it also reduces running efficiency because it makes it harder to actually maintain speed without fatigue. So things that you can consider is that you want to land your foot a bit closer to your body to actually reduce this force, so that it's easier on your joint. So many people will actually ask, what about sprinting? In sprinting, your legs spend more time in the air, so overstriding is actually natural. Or what about running downhill? Sometimes a slightly longer stride will actually helps you to maintain momentum. And you are right. Overstriding is a common phenomenon, but mostly for recreational runners or new runners on flat ground. It's less of an issue when you actually sprint or when you are running downhill. So the intention of this slide is to help you to focus on correcting your stride when it really matters. Not every time when you run, you need to actually correct your overstriding. Another common things that affect runners is how your ankle actually move under uneven surfaces. So uneven surfaces we are talking about is like grass, trails, or even stepping off on a curb when you are running. How your foot actually moves when it actually hits the ground. So if you have dealt with like repeated ankle sprains, shin spleen, knee pain, it's not so much about your shoe sometimes, or maybe how many miles you run. Often it can come down to your foot mechanics too. So we have three over here. The first one, which is excessive of foot rolling inwards, which we call pronation. When you do it too much over time, you actually put extra stress onto your shin and your knee, and is strongly linked to shin spleen. The second one, which is a weaker push-off. When your foot doesn't stiffen at toes off, instead of springing forward, your push-off feel very, very soft, very wonky. This will actually make you be more prone to feeling more unstable when you're running on uneven ground. And then the third one, which is excessive supination, where you are running too much on the outside of the foot. So this overloads your ankle and raises the risk of sprains or even stress fracture. So what is the sweet spot, you may ask? The sweet spot is you need to let your foot just roll in just a little to absorb shock, and also make sure that it pushes off strongly through your toes without collapsing in too far inwards or too far outwards. So when you're running on an uneven surface, it's very important to actually find balance, because that will actually create a safer and more efficient run. So after sharing the different running variations in the past few slides, you might be wondering, so what is there such a thing as a normal or abnormal way of running? Like I said, there isn't a single perfect way to run. Variations are perfectly normal. What matters is whether you are having pain or recurring injuries when you run, and not how much your stride actually looks like. So I think it's very important to listen to your body. If you feel any discomfort in your ankle, it is a sign that your body may not be adapting very well to the load, to the uneven surfaces. Then you might want to actually adjust gradually to help you reduce that discomfort. So speaking of that, what can you actually do? So one of the few things that you can do to reduce the load over your legs or even your ankle is that you want to try landing closer to your body so that you can actually reduce overstretching. You may even consider taking shorter and faster steps to increase your cadence. So a few things that you may consider is that you can count your step. So you can use a watch or app to track how many steps you take per minute. And then you want to gradually increase by about 5 to 10% at a time to avoid overloading your legs. You can even consider using a metronomes, just by Googling metronomes on your phone, or even using Spotify music to find a beat that actually match your target cadence. Some apps and some watches often have built-in cadence cues. You could also use that to help you run better and more efficiently. And you also want to land softly, run on even ground when possible to reduce the stress on the ankle. And lastly, if your foot rolls in too much and you don't push off as well, then you want to actually consider strengthening your foot and ankle. So small changes can make a very big difference. You don't want to worry so much about forcing a perfect running style. The goal isn't to change about how you run. And a lot of time, this kind of running tips works best when you also build strength to your ankle and foot, and also pay more attention to how you feel after the run. So let's say you do pick up an ankle or foot injury. How do you get back to running safely without rushing and risking re-injury? That's where this simple step-by-step approach will come in. There are 5 steps over here that you can actually follow to help you return to running safely after an ankle injury, the first step is that to make sure that you have pain-free daily life. And what I mean by that is that you want to make sure that climbing stairs or walking to the MRT doesn't hurt before you actually progress to running. But if it hurts a little bit, okay, what you want to do is to maybe start with some gentle strengthening, okay? You want to take a look at your ankle. If there's any swelling, you may want to actually consider icing during the first few days to just monitor, okay? The importance of strengthening in this step is crucial because in order to move on to step 2, you want to make sure that you're able to do 20 single leg calf raises without pain, okay? That is your checkpoint before moving on, okay? You can use just your body, you don't need any fancy equipment. So once you're able to do 20 single leg calf raise with no pain-free daily life, then you can actually start commencing a walk to jog program. So in this walk to jog program, what you can start with is maybe you can consider beginning with about 1 to 2 minutes of fast walking, then to a jog, and then you want to repeat for a few intervals. A simple trick over this period is to use your watches or your metronomes to actually help to keep the pace. You want to think of it like a rhythm for your feet. And then once you feel better, you want to slowly increase the frequency of this run. You want to actually do about 2 to 3 times per week or maybe per month, and then let yourself feel good about it before increasing more intensity, more distance, more frequency. So it's very important that at step 4 and step 5 that you do not want to rush. You want to let your body guide you. And if you remember the previous slides when I actually mentioned about you want to avoid a sudden spike of more than 10% per week, you want to actually take more cautious within this step 4 and step 5. Because if let's say you increase too much, then your ankle may not be able to adapt to it, and then you may actually start to have discomfort and it will actually slow you down. So when you are coming back from an injury, or if you have pushed a little bit too hard during step 4 and step 5, what you might want to look out for is that some of the serious signs and not serious signs. So for serious sign, if you can't put weight onto your foot and take more than 4 steps and swelling and pain don't improve, then I think it's important that you stop and seek for medical professional advice. But if it is just a stiffness, like a mild stiffness in your achilles that eases within a day, I think that's usually your body way of telling you that it's adapting. So I think it's important to just keep monitoring, carry on with your routine, and most importantly, listen to your body about 24 to 72 hours before you actually continue. So sometimes after increasing the distance, you may start to feel that you may have swelling, and then maybe you're running at night and you actually can't find a clinic to see a doctor. What you can actually do, like what Zhongxian has mentioned, is this to basically ice and basically protect the area, to basically re-unload it, to basically monitor for any change in terms of the symptoms. So the good news is that injuries don't have to stop you from running long term. Injuries are preventable. You want to be ready to adjust your running style when the conditions change, like for example, terrains or when you're feeling tired. You also want to don't ignore any early pain in ankle. You want to reduce the load early whenever there's any discomfort going onto your knee, when there's swelling, when you can't walk for more than 4 steps. And you also want to work on your strength, balance, or flexibility before problems appear, because this gives your ankle more capacity to handle the load when running. And most importantly, when you have an injury, okay, I think a lot of people tends to neglect this, is that the post-injury rehab. You want to do it more thoroughly. You want to actually follow us more critically because you don't want to just rest until the pain goes because that won't really help you to get better. In fact, you want to actually rebuild more control. You want to rebuild more strength. You want to rebuild more flexibility as well as balance to help you to prevent your recurrence of such injury again. So if you follow these steps, you can also listen to your body, progress gradually, and that's how you will actually come back stronger and safer. So remember, running should build you up and not break you down. Listen to your body, enjoy the process, and don't be afraid to ask for help along the way. If you are dealing with any problems on your ankle, you might want to let a healthcare professional, like a doctor or even a physiotherapist, to guide you through your recovery. And this is my last slide. Thank you for your time.
Okay, thanks, Jason. I think that was a great talk, especially about different running styles and individualized kind of prevention and all those strategies to returning back after ankle injuries, because we see so many of them, whether they undergo surgery or not. There's a rehab that needs to be taken to safely return back to your previous level. And so now we come to the portion for Q&A. I mean, all along, some of us have already been answering questions on the Q&A chat. So, we can answer them live as well now after the talks are done. So, I think there were a couple of questions on whether running is suitable for older people. So, I think Adriel, do you want to take that question for seniors and older people, whether running is suitable as a sport?
Yeah, certainly. I think for elderly who want to take on running, I think of course the general advice start slow, start with short distances first. Maybe even just start with a brisk walking. Whenever you want to start running, maybe go with softer surfaces. My own personal preference, go to a stadium, and you slowly build up from there. Be it even if it's 1 or 2 kilometers, is also a good start, and then you slowly increase your distance. Maybe by 5 to 10% every week, for example. And if there's no pain, then you can slowly, gradually increase. That will be my general advice. Of course, that is encouraged, like to have regular, running for seniors. Yeah, to maintain their aerobic fitness. Yeah. So any other queries? I think no. I also see there's one question about cooling down or warming down after a run. I think generally of course when we do a hard run, a warm down run that takes about 10 to 15 minutes, just a very light jog is advisable, followed by stretching. I think we can even do a swim down or even cycling just to cool down the muscles and all that will be helpful as well. Yeah.
I think there were also several questions on brisk walking versus jogging and running. And essentially, they are similar types of exercise in a way, just at different intensities. So the main difference between brisk walking and running is that when you are doing walking, essentially at any one point in time, one of your feet is on the ground. At least one of your foot is on the ground. But when running, there are portions of the cycle where both your feet have left the ground. And therefore, because of this difference in the way the exercise is done, running or jogging, which is the same, has the higher impact per step versus walking, where if your body is always supported, then the impact is less per step. So for people who have not been exercising before and all that, of course, we'll recommend that brisk walking may be a good way to start off, just to get your body moving. And then, of course, as if you feel good, then of course that can gradually progress to light jogging. And as previously mentioned by both Jason and Adriel, the gradual increase in distance and intensity can then build up. If you have not been exercising before, then you may even consider getting a personal trainer or somebody to come up with exercise program safely for you to prevent injuries. Because for many of us, especially if you're older or have some medical conditions and all that, you'll be more prone to injuries. And once you have any setbacks, then of course it can disrupt the whole idea of keeping fit and all that. So so in a sense, I would say that brisk walking is kind of like a lower intensity form of exercise, but it can be very useful as well. And either way, good shoes and all that warm up and cool down will still be important to prevent injuries and to follow kind of a gradual increase, and that will be useful for many people.
I think there's also a question about whether balance or even hopping exercises are too challenging for the elderly. I think the answer, uh, my perspective is that it's not always, because balance and light hopping exercises can be very beneficial for older adults when it's done safely and at the right level, because they help to improve stability, coordination, and also reduce the fall risk. Of course, it should be tailor made. So you want to actually start with like simple balance tasks like standing on one leg with support, to make sure that it's safe and comfortable. And always make sure that you consult a physiotherapist if you are unsure. And I think there's also a question about whether should I wear sports shoe when doing the exercises. I think it really depends on the goal of the exercise. If the exercise is about strengthening the foot muscle and improving like ankle mobility, doing it barefoot is often better. You get more activation of the small stabilizing muscles. But if you're doing more high impact or even maybe like such as like maybe mountain climber or maybe like the pogo hops, then sports shoe can provide and cushion your joints a little bit more, and they are also quite similar to running. Yes.
Jason, since you managed barefoot, I noticed a question on barefoot running. And what are your thoughts on this?
Personally, I don't necessarily think that barefoot running is bad, but I think it is important that you gradually load yourself. But of course, if you do have any ankle injury, I think it's better if you can actually wear a supported shoe to run.
Hello. I think there are lots of questions with regard to footwear, whether, what sizes you should get, whether you should get them with soft or hard for plantar fasciitis. So normally for plantar fasciitis, we don't recommending having too soft a shoe. You would want something that gives you adequate support, and it should fit you well. With regard to the size, no, I don't think you should get a size that is one or two sizes bigger than your actual foot size. It's just that you need to have adequate clearance for your big toe or your lesser toe, whichever is longer. I think the recommendation that the podiatrist has told us is that you should be able to have one finger just beyond the edge of your shoe, of your toe, so that your shoe should fit where you have your one thumb just distal to it. So that would be a suitable guide. If you go with one size bigger, it may not necessarily, it may be too big or too loose. So you don't want to do that. So my recommendation is to see a podiatrist. They'll be able to guide you with regard to what shoes to get, what size, and because they'll do the measurements for you, and they do have a pamphlet with the recommended shoes, which you can go and buy the appropriate size for.
Okay, there's also some questions on steps a day and total distance. So some people ask if the 15,000 steps is okay, 10,000 is okay, whether there's actually a threshold, that our body can take. And the truth is that firstly, it can vary a lot from person to person. I mean, it depends a lot on what you've been doing before, what's your age, fitness level, any previous injuries and all that. So I'll say that there isn't a black and white line that said, okay, more than this is good and or less than this is good and so on. But it really depends on what you've been doing daily, whether you can take it, whether you feel that there's any pain or discomfort when you're doing this. So for example, I recall that when we first started the 10,000 step challenge some years back, a lot of people who have not been doing anything suddenly started wanting to walk 10,000 steps a day. And then because of this lack of a gradual build up to that, a lot of them then started having pain like plantar fasciitis, heel pain, etc., and all these problems. But then again, nowadays, many people have incorporated this kind of increased walking and distance in their lifestyle. And so if you're used to it, actually it's quite okay with the appropriate footwear, well-cushioned footwear that's appropriate for your feet and all that. Most people can easily walk 10,000 steps a day without many issues. And same goes with most other forms of exercise. So I think the key is really a gradual build up. And if you've been doing it for a while already and you haven't had any problems, it's probably safe to continue. And I wouldn't say that, you have to stop because it's too much for your body or anything like that. Yeah. Okay, somebody has asked if bunions also can cause heel pain and ankle aching. And so while bunions alone, which is another foot deformity in the toe, we've covered this in the previous webinar as well. So this, is a foot deformity in the toe, but it is often associated with other problems like flat foot and tight calf muscles and all that, which can then also lead to heel pain and other problems. So while the bunion alone doesn't cause the problem, it may be a sign that you have other problems in the feet that can be triggered. And these often come together. So when you come and see one of our foot and ankle specialists, we can do a thorough assessment and determine, what is causing the problem and, how to best remedy it, what kind of shoes or whether seeing our podiatrists and physiotherapists will help. And oftentimes a combination of these things will help to alleviate some of these symptoms.
Just to add on to that, I think in the retail stores at least there are some shoes that come with white toe boxes. I don't think it's very common, but they are available. I think if you go to a reputable store, they should be able to recommend you. It might help if your bunion is not too severe to just relieve the pain, or if you're running and you have some bunions, yeah.
So I think there's also a
Definitely.
question.
Sorry.
Uh,
Jason, please carry on. Yeah.
Okay. I think there's also a question about why some young seniors couldn't balance on one foot. Can ankle injury actually contribute and how to actually improve? So balancing on one foot usually uses many systems together, your muscle, your joint, your ear, and even your brain coordination. So sometimes as we age, then these may actually weaken a little. Previous ankle injury can also kind of reduce ankle stability because the joint and surrounding muscles may not be responding very quickly over there. But the good news is that you may want to actually consider strengthening your foot and ankle muscles. And also you want to actually start with simple balance exercises by supporting yourself onto a wall on two legs first, followed to single leg. And then gradually your body will adapt and the balance will improve. And there's also a question about what a proper gait cycle actually looks like and whether is it important for us to actually push off with our toes. A normal walking cycle has three different phases, heel strike, and then after that putting your foot onto mid stand and then pushing off. So typically you want to land gently onto your heel, roll through the middle of your foot and then push off with your toe. So the toe push off is important because it helps you to move forward smoothly and more efficiently. If you actually skip it, your strike becomes shorter and less powerful. So yes, I think we should basically finish each step with a gentle push off on the toes. Yes. Dongsen, you can carry on. Thank you.
Right, yeah, sorry. Because I saw a couple of questions regarding foot massages, foot reflexology, be it the ones you get massaged on by a masseuse, or like even in the public parks where you have this cobblestone pavement. So all of them can be useful if you do find relief, but it will not change your underlying structural or mechanical issues, but they can offer temporary relief of the symptoms. So it's a little bit like having massages when you have a bad back or back neck or shoulder. It can give you relief, but the underlying problem of a poor balance, conditioning, or even a structural injury may not be corrected by it. So by all means, but if your symptoms become persistent and does not get alleviated, do seek further attention for treatment.
Okay, I think actually we've kind of already overrun our time for the webinar. So it's supposed to end at 11:30, but we have come on to 11:45. So I think we have pretty much answered most of the burning questions, uh, including on footwear, type of exercises, and certain the common conditions. So I have to kind of close the session today. And I see that there's still a bunch of questions coming in, but unfortunately, because of the time constraints, we won't be able to answer everybody's questions. I hope that we have managed to, however, cover most of the queries and common queries as well. So if you have any further questions or any conditions that that you've suffered during running, please feel free to make an appointment to see us and our team for consultation. Or you can see your polyclinic doctors or GPs as well as an initial consult if you think that it's not so serious, just for a checkup. Okay, I encourage everybody to stay active. Okay, don't let injuries and all these things, uh, setbacks stop you. You can always recover from them, and we're here to help you every step of the way. So I would say goodbye to everybody for now. Look out for our next webinars and our next sessions. You can follow us on our Instagram, SGH Foot, as well as on the SGH channels. The webinar will also be available for watching if any of you or your friends have missed out this time. Okay, you can see it on our SGH YouTube channel. And I look forward to seeing you again next time as well. Okay, thanks everybody.
Yeah.